checking their emails and looking after 5 consultants, you might not be able to find that nurse. You might have to shout outside the room, and there are logistics in getting somebody in, and the patient will usually say, no, don't worry, it's fine. And then you end up being a bit forceful, saying, no, I've got to, I have to, and it's important to document the name of the chaperone and get them to sign, because if medically this comes back to you, you need to prove that you have taken those extra steps. Part of it is actually doing a proper examination. And I think it's well known that patients don't feel like they've had, a good opportunity or a therapeutic relationship with you unless you have fully examined them. And for pelvic floor, that often means standing up, bearing down, possibly squatting, sitting on a commode, lying on your front, sometimes lying on your back. So it's, it's a bit of a battle in a gym. And when the patient comes in a wheelchair without their carer, your heart is sinking even more, because really you haven't got time for this. Once you've done all that, there's lots of discussion about the tests. And, I'm sure most of you have had the opportunity to explain to patients what a proctogram is, but it's a very embarrassing test. And the only sort of good godsend about the test, the proctogram we do, is that it goes on in COSHAM, and that the nurses are really nice to the patient. So, being asked to sit on the toilet, strain and do a poo and not be embarrassed about it behind a screen and try not to make noise and maybe not really fully perform is a horrifically degrading experience. I think quite similar to the old-fashioned barium enema, where you would be winched in the air with your bum in the air with, barium pumped in your bum, gas pumped in, and then you're sort of flaters passing it out around the room. I mean, these are really embarrassing tests, but it's really the only thing we look at in the pelvic floor MDT with any sort of consistency. So it's a really important test, and it's important to sort of warn the patients what they're letting themselves in for. So when you're in the clinic, I think the specialism is important. Have you got an interest in this? Your own particular expertise. I think it's important to say what your experiences are, and there is a personality element to it, and I think what I've seen in the world of colorectal is that there's quite a few consultants trainee that just say no, I'm just not doing it. So if you know straight away you haven't got the right personality for it, that's great, because I think if you're going to embrace it, you've got to sort of jump in with both feet. The surgery, well, we'll come on to surgery at the end of the talk. My experiences working in North Bristol is that, there is a drive, which I'm sure is nationally, to not have as many follow-up patients, to see, a high ratio of new to follow-up patients, which is difficult for pelvic floor because it is a long-term condition. And if you imagine it's on a trajectory where certain things happen in your life, for a woman, for example, childbirth, menopause, there is no one thing that's going to work, and it is sort of a lifetime. And if you end up on that pathway early on in life, from the start of an OASI, let's say, we'll come on to that in the next talk, then, is it realistic to think you're just going to do one procedure, then get rid of them? Actually, it is a long-term condition, and I don't see appetite in the NHS to follow them up regularly. So I don't know what the solutions are, but we'll probably need to come up with something virtual, a bit like IBD patients, where they can phone up when they have a problem. There's certain conditions that I think we'll all agree make your heart sink. ODS, obstructive defecation syndrome, functional anal problems, vaginismus, and perineal pain. So just a little refresher, the recent NICE guidelines change in the last few years, which pretty much dropped the age criteria for investigation or exclusion of cancer down to 40 and above, and basically any GI disturbance pretty much for patients over 40 with a positive fit now needs sort of colonoscopy. And that basically opened up the sort of breadth of referral. So we sort of suddenly, this was the pressure on colonoscopy. And this slide, I think this is the real reason for why pelvic floor surgery is a thing, childbirth. So here is the baby's head. I know it's a very crude picture, and there you can see at the bottom by the nose and mouth, the perineal tear coming onto the anal sphincter. And it's not just that small area that's the problem. If you look at the size of the head and the diameter to which the levator ani has to separate, it's easy to see how that rarely goes back to the midline, even if you ignore the perineal tear at the bottom, that stretching means that those muscles, almost like a, you know, diastasis within the rectus abdominis, you know, is very hard to come back to the midline. And if you're not someone that regularly does pelvic floor exercises and just leaves that, the weakness in the middle is where the hiatus comes, and where the weakness comes with age and then menopause. There's also this, which really just cannot help the situation and is responsible for a large amount of pelvic floor weakness within men. So we'll start with obstructive defecation syndrome, which is basically you just can't do a poo. And, you know, we do all our sort of fancy tests, and I'll come on to it, but basically the simple test, which is, I'll just stop sharing for a minute. In manometry, we blow up this balloon here, with a syringe to sort of simulate a poo. We go up to about 90 mils and we ask patients to just poo it out. And if they can't poo it out in under 60 seconds, that would qualify for a diagnosis of obstructive defecation syndrome. Well, I'll just go back. Okay, so the things to exclude as a surgeon is there some anatomical blockage that is stopping that poo come out? So it's very simple. Have they got hemorrhoids? Have they got rectal prolapse? And I'm sure you're all aware that, you know, there is a massive investigation going on in this hospital for this specific issue. Did a patient have rectal prolapse that would then warrant surgical intervention? And in our hospital's case, it was a rectopexy. But prior to the rectopexy, it was a STAR procedure, which, for those of you who aren't sort of colorectal trained, is basically a stapled anastomosis at the low rectum, removing a chunk of sort of just above the dentate line with a bum gun, a bigger bum gun to the one we normally use for anastomosis. So in a way, that brings it much more surgically and less functional. You know, is there a problem and can we fix it? So you can score this with a St. Mark's scoring system. You can measure it with a balloon. You can get them to sort of evacuate the balloon, and you can look inside the anal canal to see if they've got hemorrhoids and are the hemorrhoids starting to prolapse. And then here I've got this, I did this ridiculous video for the GPs, but I thought you might like to see it, which is the development of hemorrhoids. And then what then happens is, you know, for women, say who've got chronic constipation, they keep straining throughout their whole life, nice big fleshy anal lumps, and then eventually the distal rectum comes out. And that's where you get this sort of double bulge of the prolapse. I don't know if any of you have seen this, the bit in the middle between the hemorrhoids and the rectal prolapse, you actually see the dentate line on the outside. So that is a sort of cautionary tale for people who have long-term obstructive defecation syndrome and continue to strain down. So anal spasm, anismus, which is a sort of a colorectal version of vaginismus, which I think fundamentally is an increased tone within your levator ani muscle, which is, you know, much more common in people who have anxiety, who are really quite stressed, who carry their tension in the pelvic floor, this sort of inner clench, I call it. And it can lead to lots of problems from a vaginal perspective, difficulties with intercourse or loss of libido. With anismus, it basically sort of boosts, it adds weight to the anal sphincter, and it means that every time a person tries to open their bowels, it's almost like a shut door. And so to overcome that pressure, patients inadvertently strain. They will deny straining to you, but when you feel the tension, you can barely get your finger in to do the PR. When you ask them to clench, it's really tight. And you know that when they come in with this condition, you've really got to exclude all the other sort of obvious causes, which is a fissure, fistula, hemorrhoid. You've got to look for prolapse, which would be really hard in clinic if they're tensing their pelvic floor. Discussing anxiety is really hard because in my experience, most patients go, no, I'm not an anxious person. But when you dig a bit deeper, actually they get very stressed about everything, that they just don't recognize it as a thing. And the biggest area of blancmange is the sort of anismus of no known cause. And you can see it on a proctogram. You can see, you know, a patient really tensing their pelvic floor as they're trying to evacuate their rectum. So it's a difficult condition to treat. And that brings us on to the category of functional anal disorders, which the Rome criteria gives specific codes to. So by the time you get down to this, you've excluded your cancer, you've done all your fancy pants tests, and you're giving a patient a functional anal disorder diagnosis, I would recommend that you look at the Rome criteria and come up with a specific code, give them a specific name for it, levator ani syndrome, proptalgia fugax, because it really helps patients to be validated that, yes, they have a symptom that's got a descriptive term, and the hope is that there is some treatment available. But I think the very first step is to validate and say, yes, you have got a problem. This is what we think it is. And then you can start to talk about multidisciplinary measures. And this, I just thought I'd put this up for a bit of a laugh. Proptalgia fugax. I don't know if any of you have made this diagnosis, but I love this on the NICE guidelines. It says, once the diagnosis is made, reassurance is usually sufficient. Now, that is not my experience at all. The symptoms are so transient that drug therapy is rarely needed. The majority of patients I see with this condition are already on pregabalin, amitriptyline, citalopram, and are under the chronic pain team. So that doesn't seem to be fully reflective. And this one, even more interesting, in patients who experience frequent attacks, inhaled salbutamol reduces the duration. I've never prescribed it. And when I read it, I got all excited and thought, excellent, there's a new thing, you know, there's a new thing we can try, but I've yet to do it. I'm much more likely to prescribe these things, which I'm sure you've probably done too. Diltiazem, GTN, pudendal nerve blocks. The pain team are really good at giving pudendal nerve blocks. And in addition to that, sort of behavioral and flavor of the month, I would say, is hypnosis. The theory is that we are all so stressed at the moment because of the pandemic that very small things are causing us to be very stressed, like, you know, I've got to get on a train, where am I going to park, where am I going to sit, and leading to constant adrenaline in the circulation. And that adrenaline, unfortunately, overrides your vagal tone. And the vagus nerve is responsible for the gut function. And, you know, if you're chronically stressed, I think you're much more likely to have a functional gut disturbance because the vagus nerve just isn't working effectively. And we'll come on to that in a minute. Levator ani, this is a much more vague sort of condition, and I would usually only diagnose it in patients where I can actually palpate the levator ani muscle and it is tender to palpate. Usually the patients can't even sit down in the consultation room, so they'll be stood there. And, you know, the general sort of advice is things like pelvic massage. If you've got an enthusiastic physiotherapist, which we do have here, thankfully, at North Bristol, they will undertake a course of pelvic floor relaxation therapy. You could consider 100 units of Botox into the levator ani, but there's little evidence, as I'll come on to, there's little evidence for any operation in pelvic floor surgery. And then psychotherapy is a very difficult conversation to have. And I think at the point of discussion, the patient has to trust you. So overall, functional anal pain is really not responsive to treatment. Usually there's depression, anxiety, and in 90% of cases, we're saying we don't really know what the cause is. So it's quite frustrating for patients. Itchy bum, I'll just quickly cover it. This is the basics, which is, you know, a fecal soiling, anal skin tags, which are not treated on the NHS, excluding hemorrhoids. And then it's the, you know, the funny advice of the no tight trousers, no nylon knickers, and then start thinking about things like mebendazole. I would routinely say that to any parents to take mebendazole 3 times a year, just to take, you know, just to assume that, you know, you are at risk of threadworm, and then things like skin biopsy if it doesn't settle down. So what do we do in the world of pelvic floor surgery? Well, I've already showed you the lovely balloon. I think with any pelvic floor condition, you need to assess the structure and the function. And I've got I'll move on from that. That's a bit boring. Okay, so the anal rectal angle, I sort of briefly touched on it. You've got your lovely puborectalis coming down here like a sling, maintaining your continence at all times. You want this nice straight line on the right, which you can only get in the squatting position. So the way that we sit on the toilet is already not really the right position for opening your bowels, because it maintains that angle of continence. And if you haven't really got time to do a poo, then you'll be straining on that tight puborectalis. And so this is where the trouble with hemorrhoids comes. So an important thing is the footstool. And most patients will say, yeah, I do it. You know, they need to do it every single time they open their bowels. Anal rectal physiology is now very jazzy. We've got high definition here. You've got a red zone where you put the balloon in and we say squeeze. And when you squeeze hard and you've got good muscle recruitment, it goes nice and red. So you can use these pictures as visual biofeedback. We get some patients, particularly anxious women, where it's like a red band. They can't relax at all. And it's helpful for them to see that. So the fantastic GI physiology team work very hard at literally showing people how tense their bums are. Proctogram, here we go. So I'm going to play this and then I'll talk through it. And then, Chrissy, you can tell me what the diagnosis is.
Thanks.
Okay, so here we go. Well, I'll just pause it a minute. So straight off here, we've got barium paste that's gone into the rectum to simulate a big poo. There's a slither of paste into the vagina so we can see what the vagina does as the patient evacuates their bowel. We can see the relationship to the pelvic floor, which is the bottom here of the coccyx to the pubic symphysis. So that's the level of descent. We can see the small bowel. They've had a slug of the barium to drink. So we can see the small bowel and how it relates to somebody doing a poo. So here we go. And we're asking the patient to strain and to evacuate their rectum. And here you can see they're sort of straining and breathing and the rectum's evacuating. And then right at the end, we say, give us an extra push to make sure you're definitely empty. And there we have it. Chrissy, what can you see?
Is there a prolapse? Is there an internal prolapse?
Let me go back. It's not the most striking abnormality, but
I mean, to be honest, I don't really know what I'm looking at. I'm gonna lie.
Don't worry. I don't expect you to. What you can see quite clearly there is at the bottom, the rectum is emptied. And yeah, there's a bit of descent because it's quite far down beneath where the coccyx is. But the most striking abnormality is all of that is small bowel with contrast in, pushing like a fist on the lower rectum. So this is a really quite marked enterocele. And this lady complained of obstructive defecation and a ballooning of the perineum, which bulged into the back of the vagina. And actually the diagnosis is an enterocele, which is a real weird thing. And enteroceles are actually quite common because it's where the photo I showed you of the baby's head coming out, the weakness of the levator ani allows the pelvic contents to come to a level that it shouldn't do really. And in somebody whose levator ani is intact, the small bowel wouldn't even get a look in down there. So it's actually small bowel coming down. And unfortunately, we're not allowed to offer surgical correction for this because in the old days when we were allowed to do rectopexies for conditions other than external rectal prolapse, it would have been fair game. Whereas now the doors are shut, we can only offer rectopexy for people who've got external rectal prolapse. So when we're doing these tests, what are we looking for? What we want to know is your internal anal sphincter intact? Now, the reason we want to know that is because that provides continence control minute to minute, and that's under tonic contraction. So that's one of the most important things. We then need to know the length of the anal sphincter. And it's shorter in women at the front. For a man, you've got a nice chunky 4 centimetre. In women, it comes down to about 2.5 centimetres anteriorly naturally before any episiotomy or forceps. The high pressure zones are the bit in the middle. You know, how good is it? Is it too high or is it, you know, a little bit on the low side? How long can you squeeze for? What is your angle? And are your rectum and vagina in the correct position or are they starting to sort of descend down? So these are the sort of basic questions, and they cannot be answered by one test alone. So the difficulty with these tests is that there's performance anxiety for the proctogram. It's embarrassing, and we get patients simply saying, you know, I don't want to have this test done, or they've had it done once. No way, I'm not doing it again. It's operator dependent, not so much for proctogram, because we can all look at the pictures. But anal rectum manometry, you know, I've been doing this in OASI, and one of the problems I've encountered is obesity. For women who've got really big buttocks pressing on the pressure on the sensor probe, you get higher readings because of the weight of the obesity, basically. So that is a real confounder. There is a huge margin of error, because for the functional tests, you know, the answer's basically, is there a problem or not, yes or no, and it's all down to you. It's a little bit frightening, which is why it's important to work in a multidisciplinary team. I think the thing that strikes fear for me is that the pooled anal fistula lists, I'm sure you've all experienced them. They usually get given to the registrars, you know, can you just do it? It's a small case. Patients bouncing sort of every 8 to 12 weeks, having bits of anal sphincter cut, never having these tests done. It almost feels like a blind procedure. And why would you want to do any anal operation on a woman who was postpartum? You know, the idea that 2 vaginal deliveries without any instrumentation can cause, there's a 20% chance of damage to the anal sphincter. If that postpartum woman comes onto your list and has an anal fistula, and it's a superficial one, it would be tempting to cut it, and to cut it without seeing the anal sphincter feels a bit frightening to me. Overall, it's not considered a very glamorous specialty. One of the things I've learned in my secondment in gynae is that the sexual history is really important. A woman might come for a consultation about a change in bowel habit when the actual story is they're not intimate with their husband anymore, and it's led to relationship difficulties, and the husband is saying, go and get this sorted out. So that is hard to unpick. And I think, you know, I did a year of gynae as a reg, and I like to think that I was okay at asking these questions. But before I sat in with the psychosexual counsellors and sat in some gynae clinics, I had to dig deep, because all I was asking was, you know, are you sexually active, and does it hurt? There we go, end of. You know, that's where it would get to. And by asking those 2 very leading questions, you don't get the real story. It's often very difficult when the partner's in the consultation too, and in lockdown they've been on their own, so that's actually been easier. The mesh group, I won't go into that. I won't go into that now. But basically, it's important to take a really good sexual history and to really think about what questions you're asking and how you can do it in a sort of very non-leading way, open it out a bit more to enable patients to be able to sort of tell you the real story. So we'll do a little run through of the treatments coming on to the surgery. So first off is definitely weight loss. The sitz bath, which I've got a little picture of, I'll show you about that. It's a medieval treatment of painful anal conditions. Footstool, everyone has to be told to use a footstool. Physiotherapy, you really need dedicated pelvic floor physiotherapists. And sometimes they do the biofeedback just with a balloon. But the GI physiologists, in my experience, with the fancy high definition kit are definitely much better at this. And the NHS will fund up to sort of 12 treatments, which is phenomenal. So that could last about 18 months. The mesh, the dreaded mesh, and I've got a slide on that in a minute. STAR, which is the stapled, you know, sort of resection of the bottom of the rectum. That, I think that has totally gone out of fashion now. I don't know. It was really fashionable 10 years ago. We did loads of them. There were complications of pain and incontinence, and I don't see anyone in the Pelvic Floor Society regularly offering that anymore. Hemorrhoidal treatments, I've got a slide for that. Botox, well, we all use it for anal fissure, so I think we're used to it. Doing the extra step for anismus and vaginismus is a little bit scary, so I would say only specialist centres for that. Pudendal nerve release is a really frightening operation that is done really well in this one centre in France, in Nantes. There's one surgeon that does it, and a few people who've tried to adopt it around the country. And what I would say is that the importance of that operation. It's a massive cut on the buttock bilaterally and slightly frightening, but the importance for that is having the physiotherapy backup. So I would say, you know, if you ever see a patient that you think might be suitable for this, then I would refer it on to someone who does it regularly. Vagus nerve stimulation, I'll come on to that in a minute. Cannabis is having a bit of a moment. Lots of patients are coming in because they can buy it on the internet. And psychotherapy, if you do uncover relationship difficulties, there are gynecologists and some therapists who specifically specialize in psychosexual therapy, where the partner can go as well. So it's just important to know that that is on offer as a treatment option. So this is the sitz bath, which I spend a lot of time talking about. And this is how we used to treat hemorrhoids before we started putting bands and injecting things and putting fancy stitches in. Now the halo stitches now a bit like a V-lock. The way to emulate this is in the squatting position. And the only way to really do it is to use either a baby's bath or to get one of those plastic trugs where you collect garden leaves. You have to be in the sitting position, and there's a whole sort of following to sitz baths, which means that the water has to be 2/3 of the way up, piping hot, Epsom salts, and you have to sit in there for 20 minutes. And for people who've got anal fissures, fistula, small rectal prolapses, any painful perineal condition, this really helps with sort of antibacterial, increasing the blood flow. And at the same time, I tell patients to sort of do deep breathing exercises at the same time. And this is really helpful for perineal wound healing. And there is a picture there with a lady in a bath. I don't think you quite get the same effect if you're in the bath, because the buttocks tend to sort of, you know, swallow up the anal canal, whereas the squatting position is much better. So I would definitely advocate this. Here you can see the anorectal angle affected by the footstool, and it's important to sit forward with the footstool too. So that's the correct position on the right-hand side. So let's start with hemorrhoids. And here we have like a whole sort of mishmash of all the treatment options: rubber bands, halo, good old-fashioned phenol. And I think the sort of Hubble trial was, you know, has been discussed at length. Steve Brown's done a good effort. Stapled hemorrhoidectomy, and you know, the purpose of this graph really came from the Raffaello procedure, which I don't know if any of you heard about it, but it's like a laser hot probe up the tail end, which sounds a bit scary to me. But the take-home message from this is, I think they're all a much of a muchness. Rubber bands haven't got the 2-year follow-up that we can see with all the other techniques. And really, if we see that the rubber band has got a sort of recurrence rate of nearly 50% of a year, you can only imagine by the second year, that's probably gone up to around 60 to 70%. So, you know, when you see how that compares to the humble, oily phenol injection, you know, I am forever surprised that we just don't have this on the shelf anymore. And some patients, you know, I think it is a little bit safer to inject phenol for the patients that come into clinic who are on, you know, blood thinning medication. Because I don't know if any of you have tried to ban someone on warfarin, but, you know, it's really not to be recommended. It's, you know, you can make a bad situation really, really substantially worse. And, you know, if you do not place those bands above the dentate line, you know, it is intensely painful. So I think, you know, my feeling about hemorrhoids is the old-fashioned stuff is probably the best, even though it's really hard to get hold of phenol these days. If you did want to do it, you would have to nick it off the shelf from the pain team in theatre. They still inject it in the spine. But trying to find that needle, you know, it used to be called a rocket needle that looked like a dental needle. It's quite hard. It's very gloopy. So you can go up the ladder, and I know that we in Pelvic Floor are quite keen on a sort of sutured mucopexy, which I think is great for the prolapsing hemorrhoid that's sort of, you know, almost instead of a mini Delorme's. So I think that would be reasonable to do. But deep down, I think if I saw those types of prolapsing hemorrhoids that were sort of starting to become rectal prolapse, I would probably still just do an old-fashioned open Milligan-Morgan hemorrhoidectomy. This is what patients get recommended when they go to see the allied health professionals, so pelvic floor trainers. So it's always important to signpost patients the equipment. And I think rather than just being told to clench 2 or 3 times a day, it's helpful for women, particularly women who've been through traumatic childbirth, to use devices in a sort of home-based biofeedback therapy. So you can get this thing in the middle, which is called LV, a vaginal trainer, that gives you a score sheet on your phone on an app to tell you how well you're doing. And TENS and Kegels do a similar vaginal probe. So I think for anyone that's been through childbirth, this is really important. And here's a little horror film. This is before and after mesh rectopexy. So this woman has got the hiatus that I described, the perineal body's given way. That's the posterior vaginal wall that's very protuberant. And there's my hand in the way, sorry, but in a minute, you'll see the rectal prolapse, which is there. So I have to coax it out, but this comes out every time this poor woman opens her bowels. And you can see that just above, just north there is no strength to that perineal muscle in the middle. There really is no strength. So she underwent a laparoscopic mesh rectopexy with a biological mesh. And I will show you in a minute, you'll see, there we go, gaping anus. That's the end result. And this is why I still love rectopexy, because with no stitches in the vagina, you can totally reconstruct that pelvic floor. It looks almost normal at the end. So it is a very tempting operation, because that is the anatomical result at the end, even without vaginal stitches. And so on we come to rectopexy, and the only indication for this operation is external rectal prolapse. There are no other indications anymore. And this is from the National Pelvic Floor database. It was presented at the Pelvic Floor Society last November. If we put a mesh in for rectal prolapse, we have to put the data into this database. And as you can see here, there are still people, probably the tail end of our practice, putting a mesh in for obstructed defecation syndrome. I can only assume that means internal rectal prolapse. And if you look at the data here, for external rectal prolapse, it is effective, successful in 70% of cases. And unbelievably, in 75% of cases for internal rectal prolapse. So the data is very compelling, but the entire community internationally has been scared off by this procedure. I'm sure you've all experienced patients coming in for a groin hernia. I don't want mesh, don't give me the mesh. So this is a very sensitive area, but the data here shows that it is 70% successful. We used to quote 95% success. We now quote 70%. And what we mean by that is, nearly 8% have no change in their symptoms, which to me represents treatment failure. And I can only imagine that's a prolapse coming back out again. It's a little bit ambiguous, but the mesh complication rate nationally is still very low, 1.3%. So what are the simple measures? Definitely regulate your bowels. It's all over the counter now. My current flavor of the month is sodium docosate if they won't take sachets. So if you want a tablet, sodium docosate. If you can tolerate the powders, Cosmocol seems to be the one that patients like, because there's a variety of flavors. I think there's a chocolate one, a lime one, as well as the sort of revolting medical orange that's similar to Laxido and Fibergel. Waist circumference. So particularly for pelvic floor, it's the visceral obesity that needs to be tackled. HRT is having a moment, and currently there are menopause specialists suggesting that women should routinely go on to HRT at 45, which is perimenopause, to prevent the progression of pelvic floor weakness. So I'm forever having this conversation, and it's not widely accepted. And in general practice, there was a problem with getting hold of HRT in lockdown. So it's not popular with GPs, but I do tend to discuss it with the majority of women around the age of 45. Pelvic floor exercises with the kit that I've shown, and physiotherapy. I think they do need a physiotherapist to show them where the muscles are, because for most people, when you do a PR and you say, can you squeeze on my finger, the buttocks go. So they need to be shown how to leave the buttocks behind and just squeeze the specific muscle. So what about the future of pelvic floor surgery? Well, it's a bit heart sink, and I am one of the most positive people, but the waiting list at the moment, the focus is on cancer and emergency. So these patients are very low priority. I've been doing a lot of telephone consultations. I call it a constipation hotline. But I think you can miss rectal cancer, you can miss pathological disease, polyps. So it is a little bit worrying, but it's possibly the future. The sexual history is really important. Your pelvic floor physiotherapist, I mean, almost worth sending every patient there, I would say. In lockdown, a lot of the patients said it was amazing being near to the toilet, so the people with incontinence actually, found things a lot better. But then what we found is that since everything's reopened, there's 50% less access to public loos. And I think that is a problem for everyone, particularly those with long-term health conditions and pelvic floor. But for everyone, that is quite life-limiting. And for most conditions in pelvic floor, I would say stick to really simple things. Don't even mention an operation. Stick to sits baths, footstools, and just give them time. There is a bit of excitement. I'm going to talk about vagus nerve stimulation in about 2 seconds. There's one paper out that shows a genetic basis for hemorrhoids, which I think is quite exciting. And this pudendal nerve release that I talked about that's only really carried out properly in nonce is now becoming minimally invasive. So maybe more people will start doing it in this country. But this is the vagus nerve stimulator. And basically, the picture on the left is where neurosurgeons implant it into the neck for patients with epilepsy and Parkinson's disease and depression instead of using ECT. More recently, the TENS machine company have developed this ear clip, and the inner ear is the only place you can access the vagus nerve in the skin. And it's really having a bit of a renaissance, this therapy. They're marketing it hard for symptoms of long COVID, so for treatment of fatigue, tiredness, depression, and anxiety. And there are 2 studies from China that have used it for 12 weeks, 20 minutes twice a day for patients with IBS. And what they've shown is a reduction by 50% of symptoms of pain, bloating, and an increased frequency of bowel motion. So I tried it on my mum, who's anti-doctor, and it looks easy to use. The biggest issue is that you've got to allow the time, 20 minutes in the morning, 20 minutes in the evening. And I've incorporated, in my sheet about it, some breathing exercises. And I think deep down, probably just doing the deep breathing exercises twice a day is probably good enough to reduce your stress and anxiety. But what you can't do is check your work emails or do a bit of work or, start writing a talk or something at the same time. So I think it's a very simple way of getting people to just stop in their busy lives and focus on their health. So this is something that's sort of gaining a bit of momentum. Questions?
I think Michael had a question in the chat, which was, how did you fix the enteroseal?
Very good question. An enteroseal can be fixed. It's a tussle between a gynecologist and a colorectal surgeon. I don't think it's colorectal surgery anymore now that we're not allowed to put the mesh in for any other indication other than external rectal prolapse. But it used to be either a gynecologist doing something called a sacrospinous fixation, which it sounds a bit scary to me, but apparently it's quite straightforward. They do a posterior vaginal incision. Vertically, they go onto the sort of wobbly area and they sort of find bits of fascia and they attach it to the sacrospinous region on either side, and that is enough to sort of hammock up the pelvic floor away from the pouch of Douglas. They do it routinely, apparently. It sounds almost a bit blind to me, but the general rule of thumb is that it's only really good for a rectocele that has a small component of an enteroseal. So for the proctogram that I showed you, it simply wouldn't work. And in our pelvic floor MDT last week, when I showed a similar picture, the consensus in the room was we are simply not allowed to put a mesh in, and the patient has, unfortunately, to live with it.
Hard lines on her. Any other questions? Fab. At this point, I think maybe, would it be okay if we had a break for lunch and came back at 1:30?
Perfect.
Thanks so much. That was absolutely super.
Okay, thank you.